All right, we are moving now to drugs that selectively modify the central nervous system. So, for the rest of this unit, we are going to be talking about agents that, rather than stimulating or inhibiting the entire CNS, are a little bit more targeted. The topics we're going to cover the topic I'm going to cover in this video is anti-epileptic agents. But after that, we're going to talk about Parkinson's disease and the drugs to treat it, the drugs to treat pain, antidepressants, anti-anxiety agents, antipsychotic agents, and finally, drugs for mania or manic depressive episodes. So starting with anti-epileptic agents, I want to say one of two things. First of all, not everyone that has a seizure is an epileptic, and not every epileptic, has what we kind of classically consider the tonic-clonic or the grand mal, previously called grand mal seizure. So there's a whole bunch of different types of seizures and seizure disorders that may or may not be related to epilepsy. Epilepsy is defined as a disruption in the activity of clusters of neurons in some area in the brain. And depending on what area of the brain the abnormal activity is occurring, that's what the seizure will look like. The diagnosis of epilepsy is made after somebody's had 2 or more seizures. So a seizure can result in all kinds of different symptoms. They can result in a loss of consciousness, but they don't necessarily have to. Also sensory malfunction or motor alteration. All of those are possible with seizures. All the symptoms, like I said, are caused by this abnormal kind of unsynchronous neuronal discharges that happen in sort of an unpredictable way in some portion of the central nervous system and can be measured if they're caught while they're having the seizure by an electroencephalogram or an EEG. That's how the diagnosis is made. So like I said, not every seizure is an epileptic seizure. Seizures can be symptoms of other underlying disorders like brain tumors, for example, head trauma, brain aneurysms, strokes. Some drugs can cause seizures, both recreational and pharmaceutical, as well as some infections of the central nervous system can cause seizures. Seizures are generally divided into 2 categories, one being generalized, the second being partial. A generalized seizure is going to be due to abnormal electrical activity in both hemispheres of the brain simultaneously. With a generalized seizure, patients oftentimes lose consciousness, although they don't have to, and they may or may not experience convulsions. But sort of when we think about epilepsy, we kind of associate epilepsy, the disorder, with the sort of classic tonic-clonic, or formerly referred to as grand mal seizures. So the 3 types of generalized seizures, are tonic-clonic seizures, absent seizures, and myoclonic seizures. Tonic-clonic seizure, again, that's the one that's most common in all age groups. It's the one that used to be called a grand mal seizure. Traditionally, the tonic-clonic seizures are preceded by some sort of an aura, so some sort of a sensation by the person that's about to have the seizure that they're going to have a seizure. The aura is different from person to person. Sometimes it's like flashes of light, maybe some kind of smell or noise might trigger them, or some sort of strange feeling. Anyway, that's traditionally the type of symptoms people refer to at wet. So the tonic-clonic seizure is characterized by a loss of consciousness. Well, I should say first by intense muscle contractions, followed by a loss of consciousness. So the intense muscle contractions are kind of that tonic phase, and then they go into what we refer to as the clonic phase, which is characterized by alternating contraction and relaxation of muscles, especially of the face, the neck, the arms, and the trunk, and the legs, I should say, as well. The seizures usually last for a couple minutes, and then the patient is really tired and usually will sleep for a period of time quite deeply, traditionally. The time following the seizure is referred to as the post-ictal state. So that's like an example of a generalized seizure. Absence seizures are also generalized seizures, and absence seizures sometimes are also referred to as drop attacks. With absence seizures, sometimes the patient will fall or stumble for no apparent reason. Absence seizures are quite a bit more common in children. The episode only usually lasts a couple seconds, and during the period of time of the absence seizure, the patient loses control of the entire body. Sometimes when that's happening, their head will kind of drop forward, or they'll lose control of their muscles, and so they're sort of slouch forward. The trunk will not be able to support the body. They're pretty brief. They don't lose consciousness in the traditional sense where you would be able to necessarily notice that they were unconscious. They're oftentimes, their eyes are still open and they're still sort of sitting there, but they're just kind of not there. They're kind of checked out for a very brief period of time. I think I already said this, but absence seizures are much more common in children. Sometimes they grow out of them, and then sometimes they progress as they get older to tonic-clonic seizures. The last one is called the myoclonic seizure. A myoclonic seizure is usually characterized by a lot of jerking movements, most commonly the muscles of the head and the neck and the upper arms. Sometimes the people seem like they're kind of clumsy or uncoordinated with myoclonic seizures. They don't lose consciousness, but they might drop whatever they're holding onto, or they may fall down, sort of similar to absence seizures. Most people who experience myoclonic seizure will also experience one of the other two types of generalized seizures as well. Okay, so then we have partial seizures, which are not involving both hemispheres of the brain. Instead, the abnormal activity, sorry for the typo there, the abnormal activity generally starts on one side and will travel a short distance and then stop. Some partial seizures are kind of progressive as well, like the seizure sort of changes as it moves through that one side of the brain. These oftentimes are referred to as simple partial or complex partial seizures. And these are, again, examples of partial seizures. Simple partial seizures begin at usually a very small kind of regional focus of the central nervous system, and the symptoms that develop will be depending on where in the central nervous system that abnormal activity is. Like, for example, if it was in the motor cortex, there would be motor symptoms. If it was in the sensory region, there would be sensory symptoms. These people oftentimes also report sort of kind of aura-ish symptoms as well, oftentimes visual, auditory, or sensory deficits or abnormalities are also classified as simple partial seizures. Complex partials, these guys usually also originate from a single point of focus, but that point of focus is generally in the temporal region of the brain. The temporal region, and I should say that these symptoms, these seizures also, people experience different sorts of symptoms, motor, sensory, etc. Sometimes these complex seizures kind of start with like a blank stare, and then they start moving their arms or legs really rapidly. That would be an example of a complex partial seizure. These patients traditionally are not very responsive to verbal commands. So if someone's telling them to do something, oftentimes they won't do it. They'll act as if they're not paying any attention. About 35% of epileptic patients have complex partial seizures, as well as potentially another type of seizure as well. All right, so that was just a very brief information about epilepsy. There's a whole lot more we could talk about. There's a lot of anti-epileptic agents. They formerly were referred to as the convulsants, but they don't always, since epilepsy doesn't always result in convulsions, the term anti-epileptic agents are probably better. And oftentimes they're abbreviated as AED for anti-epileptic drugs. There's a lot of them. I've put some on the list. Phenytoin, phenobarbital, that's a barbiturate. Phenytoin is dilantin. It's used a lot. That's kind of the prototype anti-epileptic agent drug. Pardon me. It's been around for a long, long time. Carbamazine, carbamazepine. I can't say that one ever. For some reason, that is such a hard word for me to say. That one's used a lot. Valproic acid, topiramate. These are drugs that are used a lot. We're not going to talk about each and every single type of anti-epileptic agent because it would take forever, and we are just sort of skimming. But I do want to mention the treatment goals for epilepsy and know some of them. I would like you to be familiar with the primary mechanism of action. They all kind of share a mechanism of action, even though there's a lot of different choices. And then we'll talk about some of the adverse effects and cautions for chronic use. So I've already told you what epilepsy is. You can see the stats on that, affecting a whole bunch, more than 2 million Americans. As I mentioned, the diagnosis is made by an EEG. We don't really know what causes epilepsy. It seems like a lot of these people have a heightened sensitivity to triggers, environmental triggers, and those can be things like noises. Lights seem to be particularly challenging for some, like strobe lights, for example, flashing lights, flickering lights. People who are very sleep deprived are more likely to have an epileptic seizure, or a seizure, pardon me. And people who have been diagnosed with epilepsy, if they're sleep deprived, their seizures tend to be worse or harder to control. Electrolyte imbalances is another big problem with epilepsy and making epilepsy worse for people who have experienced that disorder. So essentially anything that changes the environment, homeostatic environment, can potentially cause seizures. All right, so as I already said, they get classified as general or partial, depending on where the abnormal site of electrical activity is. That's where the symptoms more or less come from. Status epilepticus is an emergency situation where basically a seizure continues either for 30 minutes or they're having repetitive seizures without any downtime in between. So they don't fully recover consciousness in between their seizures. So the big worry with status epilepticus is they can become hypoxic because their breathing is affected by that period of sustained contraction of specifically the diaphragm and the intercostal muscles. Also, this is hugely expensive metabolically on the body, and it can lead to hypoglycemia, acidosis, or hypothermia due to all of this metabolic activity. With status epilepticus, which is an emergency situation, it's treated usually with IV anti-epileptic drugs. Valproic acid or diazepam can also be administered rectally if the person is at home when having an epileptic event, status epilepticus. So there's different options, but in the hospital, they're going to most likely use an IV benzodiazepine, probably would be the most likely drug used. All right, so one thing I would like you to know is the goal. And the goal of epilepsy, it sounds very easy, but it's much harder to achieve these goals. One of the goals is to control the seizures without too much impairment of the central nervous system, which is almost impossible with the agents that we have, but that's the goal. We've sort of changed in terms of prescribing, the practice of prescribing medication for epilepsy. Physicians have sort of waffled back and forth between trying only one drug and then switching to a different drug, or so that would be called monotherapy, or using more than one drug to try to, give smaller doses to minimize some of the side effects. It seems now, for the most part, the objective of controlling the seizures as well as possible with just one drug seems to be the going practice. But like I said, it's different, and sometimes that's not a possibility, and we have to modify that. All right, so the two basic mechanisms of action for anti-epileptic agents, the overarching goal is to suppress the abnormal neuronal discharge, of course, but the two main ways that is achieved is by first dampening the flow of ions, pardon me. So a lot of the agents are sodium ion or calcium ion blockers, channel blockers, by decreasing the influx of either sodium or calcium, which are both positively charged ions. One need calcium a little bit more specific for muscle contraction. By decreasing the influx of those ions, we take those neurons further away from threshold, decreasing neurotransmitter release to some degree with the calcium blockade. And so basically what you're doing is making it harder for those neurons to discharge abnormally or at all. That's kind of the sedating aspect of these agents. The other is to target neurotransmitters, and the two neurotransmitters that are most often targeted are GABA, which is our primary inhibitory neurotransmitter, as we know from our conversation around benzodiazepines and barbiturates, and these are the drugs that are used for this particular action. And the other is to block glutamate receptors. Glutamate is our primary neurotransmitter in the brain. It's the most abundant, and it is always excitatory. So by blocking glutamate, you're decreasing the excitability of the neurons. So ion channel blocker or affecting neurotransmitters, are most oftentimes the way we go about it. So here's a little picture kind of showing what I just mentioned and some of the more common drugs that fall into these categories. You can see up here phenytoin or Dilantin has been around forever. Valproic acid is used a lot. The one I can't pronounce also is used a lot. Here's our GABA potentiators, which we already know about, the barbiturates and the benzos. Remember we said when I covered the barbiturates, I said one of the only reasons why we use barbiturates anymore is epilepsy, and it's used quite frequently. Phenobarbital is kind of the classic. We've got our calcium channel blockers down here, our glutamate receptor blockers down there. So all kinds of options. There's lots of drugs. Honestly, none of them really seem to work better than others. I'll show you some ways to think about this in a minute. Here's another example of just the GABA synapse, which we've already spent some time with, right? So there's a couple different, the benzos and the barbiturates, which we know a lot about. Those guys activate GABA receptors, as we know. But there's some new drugs we haven't talked about. One, valproic acid, affects GABA, but it does it by increasing GABA production in the nerve terminal. So we actually release more GABA with valproic acid. And then this one down here, this one blocks the reuptake of the GABA. So it keeps GABA around a little bit longer. So all of those, in any event, all of those are going to potentiate the action of GABA, which is to it be inhibitory at the synapse. So there's all kinds of adverse effects with these drugs, and they're all different, and so they're all going to have different adverse effects. All of them are going to be sedatives, so they're all going to cause both motor and mental activity depression, and that's kind of why people don't really like them, because they are so sedating. Remember, that was one of the goals, was to control the seizures without too much sedation, which is challenging. There's a lot of liver and kidney damage with these agents, lots of blood diseases, so all these things kind of have to be watched. Kidney function test, liver function test, blood panels to make sure that somebody's not getting anemic and or their white blood cell production isn't being suppressed. With phenobarbital, or phenytoin, Dilantin, there's a lot of skin rashes. Sometimes they get sick. That's if they develop a sore throat or get lymphadenopathy. That sometimes gives us a clue that they may be experiencing a loss or an abnormally low white blood cell count. Dilantin is kind of an interesting one. I'm going to show you some pictures, which has its own adverse effects. It's used a lot. It's been around forever. But Dilantin is interesting. It causes blurred vision. It causes excess hair growth on the face and the arms. It causes high levels of potassium, which we know can really mess up the heart. And it causes like thickening of the brow ridges. I'll show you that, as well as gum hyperplasia. That's the gum hyperplasia. It's very characteristic with phenytoin or Dilantin. That's the skin rash. You can see those bumps and those red bumps, very itchy. They kind of take on this appearance. Their tongue juts out like that, like this little guy has. Here's kind of the prototype, the classic Dilantin presentation. You see this thickened brow ridge here. His tongue also sort of jutting out, and then he's got incredibly hypertrophied gums. You can't even really see his teeth. That's kind of exactly what you would expect to see if somebody's been on chronic Dilantin therapy, which somebody with epilepsy in many cases has been doing their therapy for quite a long time. Dilantin is also an interesting drug in that it can also sometimes be used as an antiarrhythmic agent. We didn't talk about that because it's not used that frequently, but it can control fast rhythms. When some other antiarrhythmic agents are more likely to cause heart block, the Dilantin doesn't. So that's kind of an interesting use. Dilantin is sometimes utilized if they were on digitalis for heart failure and they developed an arrhythmia. You don't need to remember that. Okay, so this is way more than you need, but I thought I would give it to you because you might want to have it in your notes somewhere. So here's our two big categories, general and partial. And here's the ones we talked kind of about. Here's the tonic-clonic, the kind of classic, what we always kind of think about as the classic seizure, epileptic seizure. And you can see the drugs that are used most as first-line agents. Here's Dilantin down here for complex partial. Valproic acid you see kind of being used quite a lot. That works at the GABA receptor, if you recall. Where else? Which else? Here's our benzo. Oh, these are other seizures, right? This is alcohol withdrawal, febrile seizures. These are not epileptic seizures. These are sort of other kinds of seizures. Lorazepam is a benzodiazepine, and that is one that oftentimes is used IV for status epilepticus. So there's all kinds of options, right? And it's kind of a trial and error. See what people can tolerate, what works. It sounds, again, like it's kind of easy to manage, but it's quite difficult to manage people's seizures. Sometimes you don't. Some people are perfectly managed or really well controlled on a medication, and other times they can't get their seizures under control no matter what you do. So it can be quite challenging. Here's the barbiturates that are oftentimes used in doses if you ever needed to know that, and sort of the common side effects, which we sort of already know. What you're going to remember for our class is that barbiturates, this is an appropriate use of a barbiturate, is epilepsy, and they're used quite frequently. Here's some of the benzos that are used. A lot of the same ones we've already talked about. They're useful with, again, sort of the same sorts of side effects. And here come some of our newer anti-epileptic agents for different reasons. We already talked about Dilantin, but this is the category it falls under, and side effects. These are the common side effects, and these are the less common side effects underlined, but in the italics, those are the common side effects. So you see lots of drowsiness, lots of lethargy, lots of CNS sedation, which is why people don't particularly like these medications. Okay, so that is a conversation. So again, what you're going to kind of focus on is the basics about epilepsy, and what kind of agents are used. What are the two main mechanisms of action and the goal of epilepsy treatment? Short of that, definitely don't spend a lot of time memorizing all the individual drugs. I will say that, like I said earlier, they all have kind of their own side effects that are pretty challenging in their own right. And just, again, keep in mind that they're all sedating, and that that not every seizure disorder responds to even the first line drugs. That's oftentimes there's a lot of changing around. So I hope that helped, and next time we come together, or next time I come to my computer and turn on this camera, I'm going to talk to you about Parkinson's disease. Until then, have a great day.